This is our standard disclaimer to acknowledge the funder of two different projects which has contributed to us being able to put on this session today. And also I'll be referring in the third session and a bit in the first session as well to some specific projects which we did at Che that uses a major data set. And so we have on the disclaimer our gratitude for the data holder and also for our team at Che that supports us in being able to do this research. So what we'll be covering this morning in 3 sessions. And the first session is thinking about why we use econometrics in the first place and what it is for. The second session will be thinking about understanding equations, that bit of language which is used in econometrics to try and describe the research method that's being used. And then finally, in session 3, we're going to be covering some common research methods with some examples of pieces of work that we've done, why we used them, and what we were trying to achieve through that. So the first session I'm going to talk you through is why we use econometrics and what it's for. So if we think about our individual lives for a moment and not the statistical world, we are absolutely required, perhaps more often than we think, to make decisions. And those decisions or choices sometimes can feel quite straightforward. If we're wondering what to have for breakfast in the morning, there is a choice to make, but it doesn't necessarily feel a really difficult one because perhaps it doesn't, there aren't a huge number of choices available. The choice we make has an effect immediately, but it doesn't last a huge amount of time, and it affects us ourselves mostly, but not other people. But there are many choices we have to make which feel more complicated and can be more difficult to make. Those are often the ones which do affect others, such as inviting somebody to a gathering. And they're also ones which can be resulting in a long-term effect, such as if we were to move house. And why must we make those choices in the first place? Well, ultimately, it's because we have limits in what we can do. We have limited resources, and those resources come in different forms. We have limits on our time, we have limits on our financial or money resources, and we have limits on, say, how much energy we have, how much we can put into something. And the really key insight which comes from this idea, which economists use all the time, is that if we do one thing, we make a decision to do one thing, then by nature, that means we're not doing something else. This is often referred to as trade-offs. And as well, not making a decision is ultimately a decision. So we can't avoid this idea. We have to make a choice. We have to choose one thing over another. And that's really brought to life by this stanza of a poem by Robert Frost. And it says a few things, but what really strikes me about it and how it relates to how we use econometrics and have to make decisions is this idea that we are looking down 2 paths. We can see to a certain distance down both of those paths, but the protagonist is understanding that they must ultimately pick one of them without knowing everything that's going to happen, and also without knowing what would have happened if they had gone down the other road instead. And I find that just a helpful metaphor to keep in our minds when we're thinking about using econometrics to help us make a choice. One way of thinking about it as a method is to try and see a bit further down both of those paths before we decide which one ultimately to take. So how do we make those decisions which we're obliged to make? We use lots of methods in our own lives. We use our past experience of when we have made a similar choice on a different occasion. We might use the experience of other people we know that they have made a similar choice, and we can ask how it worked out for them. Or we can use guidance from other trusted sources, which can come in a huge range of forms. It could be written resources or anything like this, which is helping us gather information to, again, see down those paths and try and understand what's most likely to be good for us. And then to expand out a little bit from our own individual choices, a policymaker has a particular set of challenges because they're obliged to make choices as well. And going back to the previous slide, I mentioned that choices can feel more difficult if they affect other people. Policy naturally affects other people, potentially a very large number of other people in different circumstances. And it is also a complex decision often as well. There are lots of available choices and there are many potential implications that the policymaker is attempting to weigh up. So they have some very difficult decisions to make. They still have to make a decision. They still have to make a decision without knowing everything that's potentially going to happen. And on top of that, some of the things which we can use as individuals to think about choices in our own lives are still helpful, but maybe not as helpful for that policymaker type of decision. Personal experience is also still valuable to them, but their lived experience isn't everybody's lived experience. It may not be representative. It may not be similar to many other people, which makes it hard to use that particular source of information, which we can use as individuals to try and make a decision on behalf of so many other people. But one thing that a policymaker can use is try and build that amount of trusted information they can draw on, which we can also call research. So to put some context on these ideas, I'd just like to present for you one example. So this was a policy about having GPs, primary care doctors in emergency departments. And the context for this was that emergency departments treat a wide range of patients. Anybody who comes through the door of an emergency department can receive some treatment, and their conditions range widely. The concern of many with emergency departments is that if there is overcrowding in those departments, then the treatment which everybody receives can be less good. And there can be some people for whom they have gone to an emergency department because that's what feels possible for them, but they could also have received similar and appropriate care from a GP. So the idea of this policy was to put the GP in the emergency department, to put them where the people are going, where some people are going. And the objective was that this would reduce the amount of crowding in the emergency department, because those who could be appropriately treated by a GP would see that GP, and that would free up the capacity of other clinicians in the departments to treat those people who could only receive appropriate care from those other professionals. This was carried out by providing funding to emergency departments in order to allow them to put a GP in or alongside the physicians who are already there. And the hoped for outcome was that patients who went to emergency departments would all wait less time. Those who needed to see a GP or could see a GP, and those who could see needed to see somebody else. And there are some questions which econometrics is able to help with a policy like this. So the top question, and many of these questions come up with lots of different policies, is, was the policy effective? did it achieve its objective of reducing the length of waiting time in emergency departments? And how big was that impact? Was it reduced a small amount or a large amount? And then we would also answer a question like, did other things happen that weren't intended, that weren't the objective? An example could be that waiting time went down, but more patients came back shortly after leaving the emergency department because their needs hadn't fully been met. And that leads to some even broader implication sorts of questions like, should the policy be continued? Should it be expanded? Perhaps if it was just provided in specific places. Is it worth the cost of the policy? Because some funding has gone in this case, and that's often the situation, that there's a cost of providing a policy. Was it worth, was it good value for money? And could the policy be improved in some way? And you might reasonably wonder, well, you don't need econometrics for that. You could run a trial. And a randomized controlled trial is often recognized as the gold standard for performing research, especially in a clinical context. But unfortunately, it isn't always possible to do, perhaps because in some circumstances it's not ethical to apply a policy to one group of people and not to another, even if it's at random. Or it might be that it's too expensive to perform that trial, and the econometric approach is substantially cheaper in pretty much all circumstances. And sometimes the policy has already been brought into effect, and what the policymaker is asking a researcher is, was this effective? In which case, it's much harder to perform a trial because it's already happened. So if we've decided to use econometrics, then what is it? Well, it's a statistical method which is trying to understand relationships. It's used to test whether X is related to Y. And we use that generic word just to try and allow us to apply the same method to lots of different contexts. So in this example given before, X would be GPs being present and Y would be our outcome of interest, waiting time, or returning to an ED shortly after leaving. And what we really want to understand, if we can, is whether X, in this case the presence of GPs, causes our outcome Y, hopefully reducing waiting time, but that requires lots of conditions, and often we can't meet those, in which case we would say instead that we're investigating an association, which is to say that in places where X is higher, Y also tends to be higher or lower. But we don't know if that is purely because of X being higher, the GP being present, or because of some other things as well, or instead. And there are various challenges with using econometrics, because while we're interested in a particular policy, everything happens all at once. There's always the possibility that some other things are affecting what we're interested in, like waiting time, and we can't see them, and that makes it difficult. Also, everything matters, but not everything matters equally. So that, for example, there could be something which is affecting waiting time to a small extent, and we can't see it. But even if we can't see it, then we can still say something useful about what the role of the presence of a GP is. And if we want to trust any answer which is given by any kind of econometric method, that means trusting the assumptions which support that method, which is why it's really helpful to think about those assumptions where we can and pose questions about, do we think those are likely to be true? Because if the assumptions are true, we turn the idea around. If the assumptions are true, then we can trust what the result says. And then we often think about what's referred to as statistical significance, which I'll return to in the second session. The statistical significance, which as a shorthand is that when X changes, Y is likely to change. It doesn't stay the same. Doesn't necessarily mean that it is clinically important. And whatever we're investigating part of the picture. We can't see everything at the same time. Understanding equations, those mathematical formulas we use in econometrics. And just to start and to maintain some context for the session, I'm just going to put up a reminder of the policy which I mentioned in the first session. So again, the context here is emergency departments, and a person can go to an emergency department in England and receive some care. A wide range of patients attend emergency departments, and they can have a wide range of conditions. It's often a concern that emergency departments can become overcrowded, and that can have an impact on the quality of care which patients receive. And one of the measures of that quality is how long the patient has to wait before they can be seen and have any tests or treatments which can be provided in the emergency department, and then to be able to leave again. So a response to this concern was to provide funding to emergency departments to be able to employ GPs to be in an emergency department or to work immediately next to it, so alongside it. And the hope was that patients for whom seeing a GP was an appropriate thing to happen, but they had come to the emergency department, they could see a GP, and that would free up capacity for other kinds of clinicians to see patients for whom seeing a GP wasn't the best for them. And the hope from that is that all patients who attended emergency departments would wait less time. So we investigated the effects of that policy through regression analysis, which is used throughout econometrics. It's a key tool that's used aiming to understand the impact of what we normally call a variable of interest, such as the introduction of a policy like GPs in emergency departments, on some kind of outcome. As mentioned in the previous session, sometimes there are multiple potential outcomes. So we could think about waiting time as an outcome. We could think about the likelihood of reattendance or readmission coming back to the emergency department shortly after leaving as an outcome. So the regression analysis is focused on this idea. Does a change in X lead to a change in Y? We know that there are other things going on as well, which can affect both things, that variable of interest, GPs in departments, and the outcome. And so we want to account for that as much as we can. There are different ways of doing this, of trying to answer the question, and economists use equations to summarize the method that they're applying, how we're trying to answer those questions of interest. You can tell a lot from an equation about what the researcher is trying to do, but it has its own language. So understanding and some idea of what that language is and what it's trying to tell us can help us in, therefore, using the equation essentially to understand what the researcher is trying to do. And the attempt is to do this in a hopefully clear and succinct way. But what we're going to do in this session is to think about understanding that language. There's also quite a lot of jargon here, and one of the challenges which we face is that some of these things have multiple names and different researchers, or just even the same researcher in different presentations, will use different terms to mean the same thing. So this table is here just to present some of those key ideas which are used in all equations, and to let you know what is actually the same thing as something else. So we've mentioned already regression and what that is, this mathematical description of how a researcher is attempting to answer a question. Y is the shorthand for an outcome. It might also be referred to as the dependent variable. We also have X. X is what can be referred to as an explanatory variable, or it might be called an independent variable, or a regressor, or a covariate, or a control variable. It's all the same idea. And there will be multiple X's in any equation as well. There's normally, as we'll go on to discuss, a most important one that the research is aimed at understanding, but there will be others as well. We then have a coefficient, and that's a number to represent the relationship between X and Y, and it says something about the size of that relationship. That earlier question mentioned in session 1 about how big is the effect is told to us by the coefficient. There's also what we call a standard error, and that's purely a statistical term for understanding how uncertain we are about the coefficient, about the value of the relationship. So ultimately, the coefficient is the best estimate. That's what we think the relationship is. And then the standard error tells us, as I say, how uncertain we are about that being the correct value, if you assume all the, if you agree with the assumptions of the equation. And finally, putting together the coefficient and the standard error, we get this idea of statistical significance. And that is a shorthand for saying we are reasonably confident, or pretty confident, that when X changes, Y also changes. And as I've again mentioned in the previous session, knowing that, or being confident that when X changes, Y also changes, doesn't necessarily mean that if X changes, Y must change, that X causes a change in Y. It's just what it is an association. So we have to start, if we build our equation with an outcome, and we're going to continue with the example of waiting time, so trying to impact an outcome of waiting time in emergency departments. This is what we want to improve, or at least what we want to understand about how a policy has an impact. We might look at several outcomes in a single project as well. And in an equation, this is usually given a value of Y, and you'll see in later slides, it also tends to be on the left-hand side of an equal sign. Another useful thing to know before looking at our first equation is that we use these things which we will refer to as subscripts, which are just small letters, normally, yes, pretty much always letters, next to something like a value like Y. And they are there to show that sometimes what we'll call a variable, so an outcome, whether that's an outcome variable or an X variable, an independent variable, sometimes they change in lots of different ways, and sometimes we know they're the same value for different groups. And this will become hopefully a bit clearer as we go through, but just for now to know, we're going to use 3 subscripts. We're going to refer to patients with I, hospitals with J, and time in months as T. And you can see that our outcome, waiting time, varies between all of these groups. So you can think of it as different patients wait different amounts of time to be seen. That sounds possible. Patients who attend different hospitals might wait different amounts of time to be seen, and patients who arrive at the hospital in 1 month or another month might wait a different amount of time to be seen. So we therefore have all three of these subscripts: I for patient, variation J for hospital, and T for time. And you'll see how those subscripts get applied to other terms. So here is our first equation. And on the left-hand side, you can see Y, which we mentioned. That's our outcome of waiting time. And on the right, we already need two terms. And the one I'd like you to focus on this slide is alpha, which is the constant term. It's standard practice in econometrics to use these Greek symbols. The main thing to be conscious of is what they're capturing, what they represent, and say and tell us about the research being done. So here is alpha, and that is what we refer to as the constant term. And you can actually see that it's a constant term because it doesn't have any of those subscripts I mentioned on the previous slide, none of those little letters. So if you look again at the Y, which has I for patient and J for hospital and T for time next to it, because the outcome waiting time can vary, alpha is constant. It doesn't vary at all. In this particular context, it represents the average experience for everybody. We don't tend to interpret it. We don't tend to draw conclusions from the value of this constant term, but it's something which needs to be in the equation in order to understand everything else as we start to introduce it. And then the other term in that initial equation is another Greek letter, epsilon, which is the most commonly used for what we call the error term, but perhaps could be helpfully thought of as the everything else term, because you can see that we know how long each person has waited. That's where our outcome variable Y came from. We know how long the average person waited, because that's alpha, and those two numbers won't normally equal each other. They will some of the time, but we need an everything else term in order to be sure that Y will equal the constant, the average, plus the everything else part. That error term also has some assumptions around it, but especially for this introductory context, it's again a term which has to be there to complete the equation effectively, and it's the everything else bit. It again doesn't tend to be the focus. Now I've added one more thing to the equation, and that is the bit we're most interested in, because we want to understand what the relationship is between the policy, which in this case is introducing GPs into emergency departments, and that outcome, waiting time, which is still there. This is the variable which tends to get most attention. And you can see we've got another Greek letter, beta 1 here, and that is the coefficient I mentioned earlier of most interest. So that is telling us that number, it would be turned into a number when you saw any results, is telling us how strong the relationship is between the presence of the policy and our outcome of interest. But you can see that nothing else is in this equation. So we just have the average experience for everyone, that's alpha. We have the presence of GPs, and we have the everything else term. And the problem for us as researchers is that if there are other important things going on, and there are lots of potential other things which could be going on that are affecting waiting time, such as how well or unwell the person is who attended the emergency department, or how crowded the department is, how well or unwell other people are. And we're not currently looking at any of that. We've just got, was there a GP there? That's not the only thing which affects the outcome. And so what we have to do is to try and think about what are the other things which could affect the outcome, what else could impact the waiting time of each patient, as well as the presence of GPs, in order to know that important coefficient, that beta 1, that relationship between GP and the outcome, is more likely to be a true effect, something that we can have confidence in. So we can add in another term. So now we have X. And there would normally be several of these additional terms. The idea of them is to think about, as I mentioned, other things which could be important. Features about, as given in the example box here, like the age and sex of the patient who's come to the emergency department. That can impact how long they wait. Other clinical factors about them, as I mentioned, how well or unwell they are. Other bits of context. Here again, we have all three of the subscripts as well. So age, the age of an individual patient can vary. And it can also vary between the hospital and over time as well. So the key idea from this equation is everything we had before is still there. We still have our constant term. We still have the policy, the presence of GPs, our variable of interest. We now have some other variables which are trying to capture other things that we can see, and we have the everything else term. So we're hoping now that beta 1, that relationship between the policy and the outcome, is more likely to be because of the presence of GPs. And then there are some things which we may not be able to see, but we can sort of get around it in a way. So we have two more terms here, and the thing to really focus on with these extra terms, what kind of gives away what they're doing, is their subscripts, those little letters again. So we've got U, we've just J, so no I and no T. So this is something that only varies between hospitals, and D with just the subscript T, so something which only varies over time. And in this case, what those are referred to in by econometricians normally are fixed effects. This is used quite often to try and understand other things which are, as I mentioned, constant except for the group of relevance. So an example would be that there are different policies in different hospitals for how people are seen, or other fixed things, like where they're located. So we can include this hospital fixed effect to capture all of that stuff. So things which are a common experience for every patient who goes to that hospital, and which have been true over time, all gets captured in this bit, even if we can't tell what value it had, even if we can't see it. We know we've captured that part. Another way of thinking about it, if we just had this hospital fixed effect, is we're comparing patients who went to the same hospital. And then we've also got our second fixed effect, and that is for time. So some things like general improvements in or changes in practice, how patients are treated, which occur across every hospital but change over time, we can capture through these fixed effects, which will be in D in this case. So that means that we're essentially comparing patients who went to the same hospital in the same month. That's useful for us because the more similar the comparison is, the more similar the experience, the more likely that we can be confident about that relationship, which is still the one we're ultimately interested in, that beta 1 coefficient, the relationship between the policy, GPs and the emergency department, and outcomes, waiting time. And this equation, intricate as it looks, is effectively base camp. It's the point at which a lot of research stops. And you can see that we have covered a lot. We've already got that key relationship, the policy and the outcome. We've got lots of things, hopefully, which are about the different characteristics of different patients in that X term. We've got things which are common across time and across patients, common experiences of patients going to a particular hospital, and anything which is changing over time, but is a common experience across hospitals and across patients. But this doesn't guarantee that we've captured everything that is important. So often we have to stop at this point and say, well, what does beta tell us now, that key coefficient? It tells us that when the policy is present, our outcome of interest, waiting time, changes by an amount. And we can say something about how large that is and whether it is likely to not be zero. But we can't say with a great deal of confidence that the cause of the change in Y is X itself. So with this sort of equation, we would almost always say this is an association, but we wanted to still try and get to cause, to be able to say with confidence that because X changed, Y changed. And in the third session, I'm going to be presenting for you some of the ways that econometricians try to achieve that goal with some policy examples of where it was done as well. Thank you. Okay, so for this third and final session, we're going to be talking about some common econometrics methods, and specifically we're going to be going through 3 policies and 4 methods. So when we're thinking as researchers about how to try and evaluate a policy, we're first thinking about what questions we've been asked. Some quite common ones are, did the policy work? Did it achieve the objective it was aiming to achieve? Should it be continued? Or could it be changed in some way to improve it? And how those questions are best answered is often determined by what we know, what we can see about the policy and its effects. And we often use how it was implemented as well to try and pick the right tool from the econometric toolkit to answer the same sorts of general questions as did the policy work. So, as I say, for this session, we'll be looking at 3 example policies and how we investigated them. So the first policy I'd like to introduce you to in this session was referred to as best practice tariffs. Tariffs are a payment. Ultimately, you can think of it as a price rather than a tariff. And the context is that there are quite a few operations which can be performed as what's called a day case. Now, a day case is where a patient arrives at hospital, they receive the procedure they need, and then they leave on the same day. And the alternative is an overnight stay. So they arrive, they receive a procedure, they stay at least for one night, and then they leave again. Now, one example of a procedure of this type is called cholecystectomy, which you may also have come across as gallbladder removal. And at the time this policy came in, there was a well-recognized in the clinical profession rate of day case. The profession felt that around 60% of patients could receive cholecystectomy as a day case, and that would be a good clinical approach for them, and about 40% would need an overnight stay to get the best outcome for them. But that wasn't what was actually happening. Quite a lot of patients, more than 40%, were staying overnight. And therefore, the objective of this policy was to change how hospitals were paid for performing this procedure, the cholecystectomy procedure, to help them move to this already agreed clinically optimal state where 60% of patients would receive the procedure as a day case. And the way that they did that was to ultimately pay hospitals more for each cholecystectomy procedure they performed as a day case. The patient arrived and left in the same day, and less for patients who stayed overnight, in full knowledge that from the hospital's perspective, it is also cheaper to treat a patient as a day case, and that while they, in the English context, hospitals retain money that isn't spent, ultimately so that they can reinvest it in improving care for patients. So there is some incentive for picking the options of the clinically appropriate ones that can be done at a lower cost to the hospital. So the idea of this policy then was to make it a bit easier. There was an expectation that there was some kind of barrier because it wasn't a clinical understanding one to having a higher rate of day case for these patients. So it was thought that putting in this financial incentive could help. And therefore the hope was that after the policy is introduced, more patients would be treated as a day case. So we needed to pick a method to evaluate this policy. And the key things we thought about when coming up with a method is what was the aim for outcome? That was this day case rate, increasing the day case rate, which was something we could see. When was the policy introduced? So we knew that the policy was introduced in 2010, and we could see whether a patient was treated for cholecystectomy as a day case or not before 2010 and after 2010. And the last key question is who was impacted? Well, everybody receiving a cholecystectomy was impacted. It's not that some hospitals were paid differently based on day case or overnight stay. They all got this same incentive. And when we see a policy where we can see where it was introduced and it affects everybody, we use a method which we would call interrupted time series. The idea is that we can see what's been happening over time, and we know at some point a policy has come in. At that point, things can change. And that method is both best represented, I think, by the graph on the left-hand side here. You can even think about the two lines, the red dashed line and the black dashed line, as the two paths, except that the black dashed line, that is what we can actually see. It's made up from all the little grey diamonds. So the little grey diamonds are the individual observations, essentially. And then the black dashed line is what we call a line of best fit. So it's a summary it's a summary of all those grey diamonds, of what's been going on over time. Left-hand side is the day case rate, which I've just labeled the BPT rate because that was the policy behind it, but really it's the day case rate. Along the x-axis along the bottom, that's time. So if I just read across this plot for you, so we have the period from the far left-hand corner up to the vertical dashed line. That's what we would call the pre-policy. Nothing has been introduced. That's why there's one line. And the day case rate is gently going up. You can see it is far below 60, which would be the clinically agreed rate if everything was going as planned. The first vertical dashed line is when hospitals were told this policy is going to come in. The incentive will be introduced. We get a little bit worried sometimes as statisticians about that period because it can change behavior. So that's why we mark it. We then get a solid black line. That's when the policy was actually introduced. And then another thing we often worry about as statisticians, as researchers, is that it's not always possible for hospitals or anything else, any other institution, to instantly respond to a policy. It can take a little time, so that's represented by the second vertical dashed line. So we kind of take that little bit of time out in this context, and then we see the two lines, which are effectively our two paths. So the black dashed line, as already mentioned, is what we saw. You can see that the rate jumped up and then continued to increase through time. And then what's this red dashed line? This is an attempt through the instructed time series method of trying to understand what would have happened without the policy. And what have we got to go on? Well, that's ultimately how things were changing before the policy came in. So we make a key and often pretty big assumption, which is that if the policy had not changed, had not come in, then the day case rate would have continued to increase in the way that it had been increasing up to 2010, up to the point that the policy had come in. Therefore, if you believe that assumption, then you can say that the difference between the red dashed line and the black dashed line is the effect of the policy. And so that's really our key idea we have to go away with for this particular method. If we believe only the policy has led to this change and things would have carried on in a similar pattern to as they were in the past, now we can see down both paths. We can see the policy introduction path and the policy not introduced path, and therefore know what the difference is. On the right-hand side of the screen here, for those who prefer to think in terms of equations or who want to relate the equation back to the graph, I've just put in the extra terms which are needed to describe the plot, essentially. So you can see that there's a term for recognizing how things have changed in the past. There's a term for the shift, for that immediate impact of a policy. And there's a term for the change in the rate of change, which is quite difficult to describe in terms of arrows, but it's essentially the angle of the line, as the angle of the line changed, the black dashed line, after the policy came in. So this is one of the nice things I think about an interrupted time series method, is that the plot that tends to also be used to summarize it really matches up with the equation. So if that sort of method is presented to you, then there are a few key questions that we can think about. One is, did anything else happen around the time of the policy? Because we assumed that everything else was the same, that the trend in day case rate would have continued as it was. But if the policy came in and something else happened, then we can be less sure that the trend of the time before the policy would have continued. That leads naturally to the second question, the broader question. Is it reasonable to assume that the outcome of interest, so the BPT rate, the day case rate, would have continued as it was? That's not guaranteed either. And the last one is there some information about people who weren't impacted by the policy, but were similar to the people who were impacted by the policy? In this particular case, the answer to that third question was yes. And it was yes because cholecystectomy wasn't the only procedure where there was a recognized day case rate which was optimal for good practice. There were some others as well, and they were also being performed by the same surgeons in the same theatres. So cholecystectomy is part of general surgery, and there were various other procedures which also had a day case rate, and we knew what a good day case rate looked like, according to, as I say, the collective view of clinicians. That opened up for us a second available method, and one which econometricians at least tend to trust a bit more, and we call that difference in differences. The really big distinction is that by having a group of people who are affected by a policy, which we normally call a treatment group, and also a group of people who are similar, except that they weren't affected by the policy. If you weren't going into hospital for a cholecystectomy, then the hospital wasn't being paid differently to treat those receiving that other procedure as a day case or an overnight stay. Then we've got this control group. And therefore we can create a slightly different plot. It looks quite similar in many ways, but it's a little bit different, and we have a slightly different equation as well. Now, on this plot, there's some familiarity. You can see the vertical dashed lines and the solid line and the dashed line. We're still using the idea that we know when the policy was introduced. Now the treatment group is a different color, but it's the same numbers. So they're now light gray diamonds are the people receiving cholecystectomies. And they, again, as you saw in the previous plots, they were gradually increasing in their rate of day case. Then the policy came in and there's a jump, and now their red diamonds are showing what happened after the policy was introduced. The new thing is we don't now have a second path, which is telling us what would have happened if the cholecystectomy specific day case rate had continued to change in the way that it had before the policy. We instead have, how did the day case rate change for other patients receiving procedures from the same general surgeons in the same theatres, but where hospitals weren't being paid differently between day case rate and overnight stay. They got exactly the same price for that. And those are the dark diamonds. It happens that the day case rate for those other procedures was initially higher than for cholecystectomy. What I see from this plot are two key things which are related to the questions on the next slide. One is that before the policy came in, the light grey diamonds and the darker diamonds increased at a similar sort of rate to each other. That's called the parallel trends assumption, because we still need to make assumptions for this difference in differences approach, but they're a little bit different. So it's the idea that things changed in a similar way over time for our treatment group, those affected by the policy, and the control group, those who weren't affected by the policy, but we think are similar. Then after the policy came in, the second thing is that the red diamonds, as you can see on the right-hand side of the plot, are much more intermingled with the darker, that grey-black kind of diamonds, because the day case rate for cholecystectomies caught up, and at the end there starts to overtake the rate of the other procedures. What's really nice about this method for us is that we can see what actually happened. So other things can change. We're no longer relying on the trend over time for the control group, those, again, the general surgeon procedures that weren't impacted by the policy, how that day case rate changed. We're not just assuming that it carried on in the way, in the trend that was there before. It can have a different trend. In this case, it was reasonably similar, but actually knowing that is really valuable for us. And there are still some questions to think about when looking at difference in differences. One is, are the groups actually similar? That's this thing that we're going to have to assume, and we can put together some reasons why that would be the case, as I did, that these are the same surgeons, that these are similar sorts of, therefore similar sorts of procedures, but do we believe that they are similar enough, or is there something else that's different about them? Does it look like the outcome of interest followed a similar pattern? So that's the parallel trends. If things before the policy, the two groups tended to move together, that provides some reassurance that they were in a similar context to each other. Could it be that people in one group could actually swap to the other group? That's potentially less likely in our specific example context. If you needed a cholecystectomy, then you still needed a cholecystectomy before 2010 or after it. But there are cases where something could be changed, or some decision could mean that you end up in one group or another, which creates a concern. Or could the policy, though intended to impact the treatment group, people receiving cholecystectomies, have also impacted the group we're using as a control group? So you can have what's sometimes called spillover effects, where like a more general part of practice has changed, and that's affecting both groups, and that distorts what we see. And lastly, were there other policies or events changes at the same time as the policy we're interested in, which could impact the treatment group or the control group? Because again, we're trying to look at the difference in differences. So how different are these two groups in the post-policy, after the policy has come in that post-policy period? And we're trying to be as confident as we can that, again, only the policy has changed. Once we start worrying that other things can affect either group, it means we can be less confident about that key coefficient, which would come back again. So, as mentioned right at the beginning, believing the result means believing assumptions, and therefore we think about what those assumptions are and ask questions based on trying to work out how confident we are in those assumptions. Now, you'll have noticed that I didn't start with the policy that I'd used in the first two sessions, that GP in emergency department policy. And the reason for that, ultimately, is that normally we know when a policy was introduced. we knew roughly when the funding was given to hospitals to provide GPs in emergency departments. And as part of this project, we asked all hospitals, when did you introduce this policy? But they didn't actually know. It wasn't really clear to us when this had started happening. And therefore, we had to use a different approach. And what we did is something which is in some ways similar. It's still using an idea of there are some people impacted and there are some people not impacted, and these two groups are quite similar to each other, except for the policy. But instead of using a treatment group and control group in that way, we constructed that treatment and control group by using the time of day. And we could do that because not every hospital simply introduced a GP immediately and that GP was there the whole time. Some introduced GPs just in the evening or at other critical times. So our assumption for this evaluation instead was that patients go to an emergency department when they feel unwell, rather than they go to an emergency department when they know that a GP is likely to be there, because there was also some separate investigations which showed that patients generally didn't know that a GP was available. So we could use that difference in timing to understand that there are some patients who arrive at an emergency department and don't see a GP because there isn't one there, and some patients arrived when a GP was present and therefore it was available to them as an option. It didn't necessarily mean they saw them. That might not have been clinically appropriate, but they had that possibility. And we call that a regression discontinuity design, where there is something which determines whether a patient is impacted by a policy or not, but it is not why we think the policy would be impactful. So in this case, patients arriving at 5 p.m. at a hospital are likely to be pretty similar to patients arriving at 6 p.m. at a hospital, or 5:30, or between 2 p.m. and 3 p.m. And because in some contexts, for some hospitals, that meant they did or didn't see a GP, we could say that they were similar to each other. Perhaps the most classic example of this is that one gains access to particular benefits based on age, such as access to the state pension. Of course, this has changed over time, but at any particular moment, there's an age when it becomes available. And it's possible to argue that people who are 1 year younger or 1 year older are reasonably similar to each other on average, especially once we account for all the other things which we can see about them. So that would be another example of a discontinuity design. So a policy which is impacting from a specific age, and we can compare to those people who are just of that age, just qualifying for the policy, and those who just don't qualify for the policy, aiming at a similar idea to difference in difference, that those who qualify and those who don't are similar to each other, except that they qualify, and therefore when they have different outcomes, we can argue that's because of the policy and not because of other differences between them. And there are again some questions to think about for this policy, for this evaluation method. How was it decided who qualifies and who doesn't? Can anybody influence whether that person does or doesn't qualify? Can they influence it themselves, such as the time of day? Or at least are they likely to have influenced it themselves intentionally? Or could, say, a referrer influence it? There's been pieces of research which think about that. So can somebody else influence whether a particular person qualifies or not for a policy? Can we actually see confidently who qualifies and who doesn't? which created some concerns for the GPs in ED's case, because if you wait in an emergency department for 3 hours, there might not have been a GP when you arrived, but there might have been a GP by the time you left. And finally, are there important differences between the people who qualify and the people who don't, in ways which would impact how the policy had an effect? So again, some slightly different types of questions related to this method, but in other respects quite similar to the to the difference in difference method. And then the last example I'm going to show you uses a common method, which is kind of traditionally the most tricky to describe, but I'm going to have a go. So this was an evaluation we did about the impact of waiting times. Waiting isn't something that we generally like doing. We would ideally see a clinician immediately when we feel we need to. Waiting is part of the system at the moment, based on how much demand there is and how much supply there is. This particular evaluation was to try and understand whether there was some specific clinical impact of waiting. So after acknowledging that waiting isn't something we want to do in the first place, is it the case that people in this case who were receiving hip replacement or knee replacement surgeries, that something about the deterioration in their condition whilst they were waiting meant that even after they'd received their treatment, there was something irrecoverable, irredeemable about that deterioration. So were their ultimate health outcomes after the procedure made worse because they had waited longer? We wanted to understand that as part of a broader question about what is the cost of waiting to patients, and that would contribute to any policies aimed at reducing waiting time. Again, I've raised the question before about, is this policy good value for money? Well, we want to understand what is the value of changing something as part of that understanding about value for money. So our outcome in this case was health after a procedure. Now, for this evaluation, for this analysis, we didn't have the luxury of something changing at a moment in time. All we had was that different people wait different amounts of time. Lots of the reason for that is because of their state of health, and we tried to account for as much of that as we could. But in the absence of a policy that would impact waiting time directly, we tried instead to use what's called an instrumental variable. So the specific thing about an instrumental variable, which in this case we use congestion, is that it is something which can change the variable of interest, which in this case was waiting time. We want to see if waiting longer means that one has worse outcomes. So the instrument affects that variable of waiting time, but it doesn't directly affect the outcome, which was the health. So how healthy a patient was 6 months after they had the procedure. In this particular example, we used congestion. And the idea was that people wait a different amount of time for lots of reasons which we've accounted for. And that's presented in the top box here. So lots of, sorry, I'll go back one step. We have various things which we account for. There are some things which we can't see, which could affect both waiting time and the outcome. So the example in this case we used was patient gait. That is how we walk. That's something which isn't recorded as part of a patient's clinical information in the data set that we had, but it's something which could affect how long a patient waits. If there's more concern that that patient's going to fall because of how they're currently able to walk, then potentially they would be treated more quickly, and it could also affect the outcome, how healthy they were after the procedure. So we had to acknowledge that there were things we couldn't see that could well be important, and therefore we used our instrumental variable, which, as I mentioned, is congestion. So the idea there was that how long a person waited, which was quite a considerable period of time, like normally several months, to go through the process to receive a procedure from first requesting it. That would vary based on how long a patient waited, varied for the reasons that we could see, also varied for the reasons that we couldn't see, but we could incorporate this instrument, which was something which congestion varied how long you waited, but congestion itself didn't affect the outcome directly. In that specific context, we use, as I say, an instrumental variable approach. It actually requires two equations instead of one, but the idea is that we use the instrument congestion to predict how long a patient will wait, and then we further use that prediction of waiting time to understand the outcome. And by doing that, we get closer to this idea that we're aiming at in all cases of a causal relationship. How exactly the mathematical bit of that works is very intricate, and it wasn't the aim of this session to describe, to have a deep understanding of that point. What's really, I'm hoping you take away is what sorts of questions to ask in the context if an instrumental variable is presented as the option. So there are two key ones, I would say. The first is it likely that what's being described as the instrumental variable, in this case, congestion, likely to impact the key explanatory variable, in this case, waiting time? Does that sound like a reasonable thing? That was the first arrow along the bottom in the previous slide. And then the second bit is the instrument likely to directly impact the outcome variable, not only because it's affecting the variable of interest, but going directly. So in this case, is it likely that if there is more congestion purely because of that not going through waiting time, the outcome of health is likely to be different? So those are the questions to ask in order for us to grasp how confident we can be in the assumptions underpinning the model, and therefore we can trust the key outcome, which would also be presented. So in conclusion, what we want to understand is what is the impact of the policy. We often can't run a randomized controlled trial to get that information, and even when we can, it has its own limitations, its own constraints in how much information it can provide. So econometrics is a set of tools which we can use to try and understand the impact of each policy. Each method we use has its own strengths, its own weaknesses, and while the conclusions drawn are often aiming to answer the same types of questions, like was the policy effective, how much one can trust that answer, how confident we can be in that answer, depends on different sets of assumptions. So by asking questions about the approach that's being used, what method is it, what's the tool, and also understanding what it's trying to do, we can assess in each case how confident we feel about the results that come out from the method. Thank you.